Well, thank you everybody for coming. Very pleased to see everyone and talkative, lively group today. So very pleased today to have with us Dr. Deshira Wallace. And Dr. Wallace is an assistant professor at the University of North Carolina at Chapel Hill. Department of Health Behavior, and is a faculty fellow at the Carolina Population Center. She's a social and behavioral scientist. She works with mixed method approaches to address health inequities and exposures, health services, and health outcomes. Specifically, she works to examine structural and psychosocial stressors on cardiovascular and type 2 diabetes prevention and management in US Latinos and in Latin America. She examines the heterogeneity of different types of psychosocial stress impacting disease progression, and the heterogeneity in chronic disease outcomes among Latinos to better understand disparities and health-related quality of life. Her research currently focuses on using participatory approaches to better understand the role of stress in diabetes and pre-diabetes management, and also the role of environmental stressors on mental and cardiovascular health of farm workers in North Carolina. Dr. Wallace earned her PhD in health behavior from UNC Chapel Hill. Okay, but wait for this one. And her BA in environmental science and policy from Duke. Yeah. I told you, half the room. Always. So after that, I'll turn this over to Dr. Wallace.
Yes. It's always a good time. So thank you so much for having me. I want to make sure I stay on time. So today I'm going to talk a little bit about 3 projects that I have that focus on both that intersection of mental health and physical health, but I also work broadly in intersectionality, the more ideal version of intersectionality framework that we most likely think about, which I'll talk about in my 3rd study. So I wanted to start a little bit with who I am, my research framing, my point of view, go into 3 studies, start with global and then move into the US, and then a little bit on some future work. So this is a picture of Colón, which is a Caribbean coastal city in the Republic of Panama, which is where my family's from, where I'm from. And this really going back and really talking through and meeting family members and just talking to community members there really impacted why I even decided to go to grad school, which was what I was hearing in public was not what was actually being produced by the literature, especially coming out of Latin America. A lot of it was infectious disease, but everyone was talking about heart issues and diabetes, and I was not seeing that in the literature. Also, this is a very Black town, and so for me, what I also was seeing in the literature for Hispanic Latino health was not really reflective of the people that I knew. And so my work, and I'll talk a little bit about my K at the end, is thinking about the heterogeneity of racialized experiences among quote unquote Latino ethnic groups. So what I'll broadly be talking about are the 3 buckets of my research, which is chronic disease prevention and management, psychosocial stress, and measurement. So I tend to do a lot on scale development and adaptation, and that's within the US and Latin America. Without further ado, we'll move into the first study, which is thinking about psychosocial stress among adults with type 2 diabetes in the Dominican Republic. And that's a map of the DR, which is on the island of Hispaniola in the Caribbean. But the population, about 11.3 million people, a little under 7 are adults. And of that adult population, about 12.7% reportedly have type 2 diabetes. However, diabetes testing is very limited in the country, especially once you move out of the 2 urban centers, the capital, Santo Domingo, and Santiago de los Caballeros, which is in the middle of the country. And I particularly work in rural areas of the DR, kind of in the middle of the country. People are always like, are you going to the beach? I was like, no, I'm going to the middle of the country where there's lights are out, water is not always available. But I actually think it's my favorite part of the country. People are amazing there. And in 2010, there was a nonprofit actually out of Omaha, Nebraska, close there in the Midwest, that created and worked with an NGO in the Dominican Republic, Catholic NGO, to develop this diabetes and hypertension program in rural areas of the DR, and they're still there. And we've been collaborating with them since. So I'll talk a little bit about some of our collaborations. But before going into what is diabetes and what I'm interested in, I'm thinking about a lot on self-management. And type 2 diabetes, we often think about as, make sure you eat properly and exercise and take your medication, but all of that requires engagement with different levels of influence. Individuals need to have, structurally be sound, so food security and housing. As if you're taking insulin, you need to have access to refrigeration, which is not always common in a lot of areas. Organizational access, such as availability of healthcare providers that are close to you and you could go to on a regular schedule. Interpersonal support, so support from caregivers and peers. From a lot of our qualitative work, we found that women indicated they had little to no social support in the household compared to men with the same condition. An individual, we know those medication adherence components, dietary changes that they need to go through, and testing. But all of that can be impacted by different levels of stress and where that stress may come from. And so we got into this understanding of stress and diabetes from work that we've been doing now going about 10 years. In 2015, I went down as a doc student, actually, just to explore the lived experiences of adults with type 2 diabetes in rural areas. We did qualitative inquiry. We did not go in with preconceived notions. We were just like, what's going on? We also interviewed community health workers and the clinicians who are working at these clinics to understand how are they supporting them. And that was about 5 years into the clinic being started, or the clinics, I would say. We were starting to learn a lot about social support and stress because it came up a lot in 2015. So we went back down in 2017 to do additional qualitative interviews with patients to understand the emotional mental health needs that they just further investigate that anxiety, depression, stress. And we just kind of focused more on that component. In 2018, we also went back down to now focus on the clinicians and community health workers to understand their perspectives of how do they feel about supporting the emotional mental health needs of their patients. A lot of them don't feel equipped to do so. They are on primary care. And so that's a new area to ask them of. And so this quote kind of gets at from one of our patient participants, kind of what they were talking about when they were thinking about stress. And so he mentioned there are people who can follow their diet, but many cannot. We often must eat things that we should not eat because living with hunger is hard. Diabetes is harder for the poor. I would say it's much harder. I feel bad for those of us that suffer from this illness. Sometimes I go to sleep hungry, and more so when one lives in the countryside. Things in the countryside are difficult. We also heard quotes from participants saying diabetes was worse than HIV for them. They had to change so many aspects of their lifestyles versus like taking just a medication that they felt it was a death sentence. So knowing this, we're trying to understand, okay, what do we know about this like intersection of mental health and type 2 diabetes? And there are existing scales. So there's a diabetes distress scale that was developed in the US with the VA and community health clinics, but it wasn't used in the Caribbean before. So I went in 2020 and escaped right before they closed the airport 2 days before to conduct cognitive interviews to determine if the diabetes distress scale 17 items required adaptation in the first place. What I did find was, yes, there were some words and phrases that people were like, I have no idea what you're talking about. So I did adjust those phrases, and I also had to split a couple of questions because I found that individuals were not responding to both parts of the item. So they focus on friends or family, or they focus on mental or physical, not both. So once I was able to do that, I ended up doing a cross-sectional study in 2003 to understand the prevalence of these psychosocial stressors or psychosocial distress, which is what I'm going to be presenting on here. So in 2003, I went down with a team of 3 students between June and July 2023, and were recruited in the 2 rural clinics. We recruited every single patient that went into the clinic that day if they had type 2 diabetes. Some individuals only had hypertension, so they weren't eligible. To account for the literacy, variability in literacy levels, everyone had the structured interviews done aloud. We had iPads, everything was spoken out loud, between 20 to 45 minutes. And we included questions on demographics, depressive symptoms, anxiety, acute stress, diabetes, distress, social support, food insecurity, and health services. I would have liked to ask more questions, but working with our community partner, they were concerned about the amount of time it was going to take. We could not impact the clinical flow. So we wanted to make sure we did not do that. And for the incentive, so this is an area where research is not really done. So we thought really clearly about what is the incentive for this time. And so each clinic has a patient association where the patients have access to those funds to decide how to invest it. So we decided to do $500 per clinic, and that came about with talking with our community health workers who thought that was an appropriate way to show support. In terms of the analysis, so we did, univariates, bivariates, but mostly I'll be showing the logistic regressions comparing individuals who indicated no to minimal levels of distress versus those who had moderate to severe or more severe, and compared them by gender because qualitatively we were hearing that men said that they didn't have as high levels of distress compared to women. So we wanted to double check that quantitatively. And then I also, because this is a psychometrics component, and that's something of interest to me, I did a confirmatory factor analysis of this to understand the structural validity of the diabetes distress scale. And these are some of the statistics I used. High-level results on the demographics. So we recruited 500 people, and within a little under 8 weeks, mean age about 62, about even on gender. Education level, as you could see, most finish primary school, and that's about 8th grade equivalent in the US. Year since diabetes diagnosis around 11, hemoglobin A1C at 8%, so which is not bad actually. And most were taking blood pressure and cholesterol medication as well, which is pretty common. So these are the forms of psychosocial distress that we were focusing on: depressive symptoms, anxiety, acute stress, and diabetes distress. And as you can see, there was a significant level of individuals who reported high levels of depressive symptoms and high levels of acute stress. So in the last 30 days, which talking to our clinic partner in the past, they indicated only 1% had indicated depressive symptoms before. So going from 1 to 20 is a bit different. Anxiety was about 10% between moderate and severe, and diabetes distress was very low in terms of severity, which we could talk about why that may be. In terms of the logistic regression for the unadjusted model, we did find that men in general reported being less likely to report high levels of acute stress, depressive symptoms, and anxiety compared to women. Diabetes distress, of course, was low across the board, so there was not much difference. But when we did adjust it for age, it did wash away. But the unadjusted model, I think, is still important to consider, given where the reporting ended up being. In terms of the CFA, we looked through and did the reason we did confirmatory factor analysis rather than exploratory was because the diabetes distress scale 17 does have a 4-factor model. So we already knew that there ideally should stay stable within a 4-factor model. But we did test 1 to 6 factors just to double check. And I showed the 1-factor and the 4-factor model, and the 4-factor model still had the best fit with the data, which means it's aligned with what we would expect given the base that we had with the scale. And this is an example, this is the outcome, the visual outcome of the 4 factors. So there's an emotional distress component, and there's 6 items there. Regimen distress, which means it's difficult for me to, do my dietary regimen every day. So it's hard for me to do like the exact recommendations. Physician distress, so is your physician the reason why you might be a little stressed out, which was pretty low in our sample. And then interpersonal, and this is the family and friends, are they supportive of you or not? And so all of these are standardized factor loadings, and they're generally large, about 0.4 and above, and they were statistically significant with all the latent variables. So it did fit well, which was good. So just to conclude this study, the adaptation of the diabetes distress scale for the DR was appropriate. We have already integrated it into another study that's looking at HIV and chronic and type 2 diabetes among sex workers in the Dominican Republic. So we continue to try to validate this scale over time. Additionally, the depressive symptoms and acute stress levels were high overall. And we did note that there were some gendered experiences there, and women were more likely to report kind of worse outcomes than men. Diabetes distress was low, and it could be primarily because we recruited from a diabetes program. Everyone is already integrated into a system of care that is sometimes their primary system of care. So we would have to replicate this with other similar public clinics, or what they call policlínicas, their government clinics that do not have a diabetes management program, to see really what it's like in the general population. In terms of contributions of this work, this adapted scale could be used in the DR and in the broader Caribbean. It's already published, so people can use it. And we are going to continue to add to the literature of diabetes care and chronic disease in Latin America and the Caribbean as well, with an emphasis in rural communities. A lot of work is done in urban settings. So having some work in rural settings where the majority of the population still live and have ties to is really important. So moving along from Dominican Republic to the US, I have an interest in diabetes prevention. So pre-diabetes related stress is something that came about actually through my dissertation work. And I've been continuously working in that space. And pre-diabetes in the United States, a lot. So pre-diabetes, although clinicians don't like the term pre-diabetes, it's this high blood glucose state that is not quite type 2 diabetes. It's a lot to say in a phrase, so pre-diabetes is the shortened version. It affects a third of US adults, and it's similar across ethno-racial groups. It's also only about 85% of people, or 15% of people know that they have prediabetes, so 85% of people just do not know, mostly because testing is really hard. If you've ever tried to get blood tests during a primary care visit on type 2 diabetes, they ask a lot of questions. And it's very difficult. And I thought it should have been standard, because it is standard in other countries. But I've tried to do it as well. And so it's hard to kind of get that information. But where we do see disparities is that ethno-racial disparities exist when we're thinking about that transition from prediabetes to type 2 diabetes. So who actually ends up with type 2 diabetes? And we know that there's some biopsychosocial factors that we can intervene upon to reduce that transition. So asking individuals to engage in more physical activity, change their diet. We know reductions in body weight of 5 to 7% actually have major impacts in reducing the transition. Sometimes taking medications. Some people are asked to take metformin. It's not always standardized. Those all can impact that transition. And what we also know is stress might be part of that component too. And I mentioned the word stress a lot, but I actually never defined it until now. But stress is that physical and mental response to some level of external cause. And it's not always bad. You could have positive, motivating stress, and you could have detrimental stress. It could also be acute. So it's almost finals week. So finals is an acute stress. And then once you're done, okay, you feel better. And then you have chronic stress, which could be things like housing instability, right? But we know that stress can impact individuals' engagement with recommended behaviors. And this is, when I did my qualitative part of my dissertation, this was one quote from one participant who I think really captured that really well. I think it's very difficult when I have stress and anxiety and I have to think about things. It's hard to live a healthy life at the same time because all I do is think about my problems. And the last thing I want to do is search for healthy food or go to exercise to distract myself. It's something I should do, but I don't. They know exactly what they need to do. She was talking about having to do yoga, but she also was talking about worried about her documentation status, worrying about sending money home, worried about like financial security. Like there's just some days that she's just like, she said, yoga is not going to make my life better. It's not going to reduce all the big stressors away. There are structural issues at play. And for me, after doing the qualitative part of my dissertation and, in the midst of the beginning part of the pandemic, I ended up having a lingering question of, especially in parallel with this diabetes work in the DR, of we are measuring diabetes distress, but is there a way to measure this at the pre-diabetes level among Latinos? And there was not at the time. And so I was interested in learning a new methodology, which I'll share. And being really cognizant of, I don't have prediabetes, so I cannot speak to that experience. I can only talk to so many people to understand that experience. So I wanted to use a participatory concept mapping approach to help me create a scale for US Latino adults, because I was going to I did it in both English and Spanish at the same time. I ended up thinking through recruitment, and to make it as broad as possible, 18 years or older, clinician identified prediabetes, which was the hardest part of the inclusion criteria, because going out into the field and asking people, do you have prediabetes? As I mentioned, 85% of them don't know. And it was really hard to recruit just out in public. They had to live in the US and participate in English or Spanish. So I had flyers, I had online platforms, went on social media, but ultimately ended up working with a community clinic in Wake County, in Raleigh, that had a large Latino population, like 60%, and 60% of them also were within this prediabetes to type 2 diabetes range. So we were able to recruit rather quickly with their collaboration. And participants were offered $50 per activity for recruitment. So group concept mapping. I'm going to go through each of these steps, but essentially it's this mixed methods approach that really seeks to bring together the values, beliefs, opinions different people have to come up and articulate solutions or develop results. And for me, my result was a scale. So I'm going to go through each step at a time and kind of show what we did. So step 1 is the brainstorming stage. We use Jamboard because we wanted to have a visual. Normally we have people in person and you have sticky notes and people like post things around. It was pandemic time, so Jamboard is no longer available. It does not exist anymore, but this is a nice online version. We kept it at up to 4 people per Zoom max, because with online you have to have smaller groups. And ideally with concept mapping, you have 1 focal question, but we wanted to I asked 3. So 1 was focused on stress during the prediabetes diagnosis stage, because what I was hearing in the qualitative interviews was a very visceral reaction. Then there was a stress related to the actual management. So I wanted to kind of figure out if there were differences there. And then the last question, which I'm not going to go into, but was about coping, because I wanted to end with something helpful within the groups so they don't feel so sad by the end of the conversation, and also to think about future interventions. So at this stage, we did several focus groups, and we got about 150 different statements. We reviewed it as a team to reduce the number that were repetitive, and then we put them in this this group wisdom website, where we asked participants to individually come back in and sort each of the statements. There were 86 total, into themes. So they would kind of group them together based off of what they deemed they were similar by, and that was really important. We had to have a minimum of 20 people do this individual activity. We also immediately asked them to do 1 by 1 the rating. So within every statement, so this first statement is available information is not culturally relevant. They had to say if it was very important to them or not very important to them, using a Likert scale. So we wanted to see level of importance and how are they grouping them together. For the data analysis, the Group Wisdom website kind of supports this multidimensional scaling. So it creates this point map and cluster maps. And really what we're trying to figure out is using these fit statistics to determine statements that are closer together on the map were frequently grouped together. And then also we're going to look at using this Ward's algorithm partition to look at ensuring that they're not overlapping, but also determining level of importance. So I'll show you what that looks like based on visually how individuals rated each statement as important. So we did the analysis, and then we come back and ask them to help us interpret these maps that I'll show you, and they were able to help us with the labeling of each of these clusters. And then that helped me draft the first draft of the scale. After I drafted the scale, then we did cognitive interviews right away to also assess the item structure, improve respondent understanding, and just understanding of the concept of prediabetes distress. So I probed for comprehension, clarity, the syntax, using a verbal probing technique. So it's essentially like an in-depth interview, one at a time, asking individuals, tell me if you understand like this phrasing, et cetera. And we did this in rounds of about 3 to 5 people so we could make edits and come back with more information. And then that was helpful for us to edit some of the items. So in terms of who participated, we had 36 participants, many of whom did all 4 rounds. Or did maybe 2 out of the 4. So several were repeat, and that's what you ideally want, especially in the interpretation. They need to have done one of the other activities first. Age range, about 46 years old, mostly women, which we tried really hard to get men to participate. It was a little hard. Heritage-wise, reflective of the US in terms of majority Mexican heritage, but we did have from Central America and South America. And we also had the majority who are Spanish speakers. So in terms of results, this is an example of what we thought of could be one of the themes, which is provider source stress. And so this participant mentioned, like, I've tried every guideline suggested by my doctor and still no results. And he kept talking through about how the doctor doesn't always believe that he's doing what he's been told to do. And that is what's frustrating him because the numbers don't change and quote unquote, the numbers don't lie, but he's like, but I actually am doing what you told me to do. And so they feel judgment from that clinician team. This is a point map. So the point map is essentially all 86 of these statements in like a spatial form. It doesn't look like much because it's a glob of dots, but what it ends up becoming is this, what the sorting stage helped us with. So the dots that are closer together were the ones that the individuals were more likely to group together, so those statements. And so we end up having things like individual level stress or future worries, which these are phrases that individuals helped us with, which future worries means I'm worried that this is becoming type 2 diabetes. It's very future oriented. But with the added layer of that rating of the level of importance, you see that the clusters that are darker have more layers on them, indicated that more of the statements were rated as most important compared to the others. So individual stress, worried about the future, mental health, financial stress, which makes a lot of sense, physical health challenges, difficulty with medical advice. Why did we want this rating component? Because ultimately we made a longer scale, but eventually we might want to make a shortened version. And when you make a shortened version, this might help us think through how do we prioritize the components or the subdomains that we need to represent in a shortened version. We can't ask participants to answer 100 questions. We don't want our clinicians to look through that and say absolutely not. So this was a really helpful, and actually we were worried if participants were okay with helping us with the interpretation session. And my grad students were like, this is going to be weird. I don't understand. And they actually understood what we were going for here. And they're really helpful in thinking about how to edit some of the themes that were underlying some of the polygons. When we did the cognitive interviews, we started with 42 items. That is a long scale. But we wanted to really edit. So we edited and we dropped 12 items because of comprehension issues, or we felt like the participants felt like it was too repetitive. But we want to make sure that we were able to fill in that subdomain. So we didn't want to delete everything. Participants felt like the items did contain enough information for them to respond to. So recall was good. In terms of decision processes, there was one question that was dropped because participants felt it could be worrisome for confidentiality. So we had a question about feeling worried about documentation status as a structural barrier. So we dropped that because they felt like it wasn't, and this was, last year we were doing this, didn't quite feel good in terms of that confidentiality. So we made sure to drop it. And they felt response options were appropriate, 1 to 5, Likert scale. And so we ended up with 29 items. This is currently under review, so hopefully it'll be out soon. And readability at 8th and 7th grade, I ideally would like to have it lower than that, but everyone, and again, we talked to people at different parts of Latin American heritage for Spanish to make sure everyone's Spanish was clear, and then for English, they understood what we were going for. And so we'll see how it goes, and if edits need to happen, we'll make it happen. So in terms of next steps, last week we just completed the quantitative data collection among 408 US Latino adults with prediabetes, about 50% in Spanish, 50% in English, because my goal is to do a multiple groups confirmatory factor analysis to ensure that the English version of the scale and the Spanish version of the scale are equivalent. I can say they're equivalent visually, but I need numbers to back that up. And then we can continue to make edits with that quantitative information. So hoping to finalize doing the analysis this summer. And then also we're going to conduct some analyses on the associations with other psychosocial stressors because we collect information on health services, depression, anxiety, etc. So that is one piece there. In terms of contributions, stress in this pre-diabetes stage is pretty understudied. When I Google and do searches, it's my papers that come up. And so I would like to have more kind of in this space. I think that developing this scale that really centered the experiences of adults with prediabetes is really important. While I could have done more literature searches and I did speak to clinicians and I spoke to nurses and dietitians also to help me think through the wording of these scales, I think it was really important to make sure I had the lived experiences of those who actually live with the condition. Also, developing the scale in English and Spanish concurrently was really important. It could have been easier to do in one language and then try next, but I think, one, I wanted to challenge myself, but I think it made sense to ensure that equivalency was kind of thought through all the way. And I want to ultimately use this scale to support shared decision-making. So I'm working on a grant to think through that next and thinking about clinical outcomes. And we've talked to our clinical partners and they like that idea of how do we think about what is actually stressing out our patients? Is it us? Is it their individual behavior? Is it something at home? And we could tailor our conversations a bit more. And then even thinking about supporting community interventions like the DPP, which does have a stress module, but there's no way to really go back to it and think through how does that kind of go through, so how does stress impact all the behaviors that they're talking through across all the weeks. And so moving on to also in the United States, third study is relevant to the first name of my K, which is also one of the reasons I went to grad school, to really think about parsing out who we mean by Latinos when we talk about Latino health research. And so in terms of phrasing that I'm using, so the words Hispanic, Latino, Latinx, Latine, these are all political identifiers that tie together a group of people based on a shared cultural history. Hispanic refers to that colonial language that's shared, the Spanish piece. Latino, Latine, Latinx is more of a shared geography. But Latinos are also a racially heterogeneous group. We know this in theory, but in practice, that racial heterogeneity gets flattened pretty often. And it gets ignored because it gets, quote unquote, difficult to measure race. And so it reduces our ability to really think through within group racialized disparities. And Black Latinos or Afro-Latinos are an underrepresented part of the Latino health research agenda. And for me, I was really interested in understanding the experiences of Black Latinos in the US South, mostly because Afro-Latinos, Black Latinos, they have a documented history in the US. It tends to be in regions with large Caribbean ethnic enclaves. You're New York City. I have a lot of family in Brooklyn or Miami, where I also went to high school in South Florida. And so, but the Southeast, or we consider the South, quote unquote, is this unique geography in the United States. Has an increased number of Latino migrants and immigrants every year. It has the largest proportion of Black people in the US, has this rich and critical history in the development of Blackness in US traditions in the United States. And so I was really interested in thinking through how are Afro-Latinos and thinking through their racialized experiences being in a space that is also pretty Black, but also not tied to an ethnic group. In New York, people talk to each other based on ethnic groups, like, oh, I'm Jamaican, or I'm Haitian, or I'm Panamanian, whatever, but not necessarily always based on like larger racial groups. So for this study, I wanted to think about intersectionality and think about the exploration of Black Latinos with chronic conditions in North Carolina. And so I recruited adults 20 years or older residing in North Carolina for at least a year who self-identified as Black. So that was really important because I'm not a psychologist. I didn't want to deal with like issues of identity formation. But also are socially assigned as Black. So if you're walking down the street, do other people see you as Black? And that was really important because there are people who say I'm Afro-descendant, but it's like my grandparent. I have one grandparent who's Black, which is fair, but that's a very different experience. And I'm interested in discrimination experiences. And so I also want to be able to have individuals who could participate in English or Spanish. I need to increase my Portuguese to include people from Brazil. I also define Black Latinos or Afro-Latinos as peoples whose Blackness is tied to Latin America and the Caribbean. So Afro-Latinos gotten so broad that for individuals who maybe have a Black parent, but that Black parent is not from Latin America, and that a Latin American parent who is non-Black, they also fit under that criteria, but I did not want to include them because I think that would still diminish this understanding that Blackness also exists in Latin America. And so thinking through the data collection, it was in-depth, semi-structured interviews, similar in terms of recruitment, online platforms, social media. We went to so many community events. And it was very hard to recruit at community events because actually a lot of Afro-Latinos don't go to those events. They did go more to Charlotte, but the ones in Raleigh, like I knew it was a stretch and it was a stretch. But a lot of it ended up being word of mouth, and it was really helpful. Like, someone and they recruited and they helped. We worked in Zoom. Interviews were about an hour at the beginning. By the end, we were getting closer to 2.5 hours. People had a lot to say. And we had field notes after every interview. I did every single interview, and I had audio transcribed. In reviewing field notes and audio and reviewing transcripts, I'm still doing this again and again because I keep finding different things. And that helped me write some memos and notes to then think about doing a matrix of comparison across different themes. In the end, I recruited 26 people. That took about 1.5 years. It took a really long time, but all amazing participants. Mean age about 40, mostly women. They had different migrant experiences. Some immigrated directly from Latin America and the Caribbean to North Carolina. Some migrated from other states in North Carolina, which is also common, and 2 were from North Carolina. Most spoke English, most were from the Caribbean, which made sense. And here are some of the countries that were represented. So we had some from Central America and South America and the Caribbean. In terms of some high-level results, so there are some intersectional experiences of Black Latinos, and participants indicated that there were unique considerations for Black Latinos compared to non-Black Latinos. And I was thinking through this from the point of view of hypervisibility versus invisibility. And hypervisibility, there's this anti-Black racism that's compounded upon xenophobia. So at the same time, there also is this idea of invisibility, which sometimes you would have to need to prove your Latino-ness in Latino spaces because you quote unquote don't fit what their general understanding of Latinos are, which came up a lot. But this is a good example. This is from a Dominican woman who's a clinician and talked about one of her mentors. She said, I have a mentor who's also Argentinian and she looks white. She's also Italian in terms of her ancestry, and we'll talk for ages about the ways in which her accent has impacted her opportunities. And that's not something that I personally have to deal with, but maybe a lot of Latinos do. But at the same time, thinking about her, if she's not talking and she's just walking on the street or driving her car, she doesn't have to be worried about being stereotyped by police officers or whatever. Whereas with my doctorate and my perfect American accent, I do have to worry about that still when I'm driving in North Carolina or anywhere. So that's what I mean when I think about it as an added layer. I must sometimes tell people there is an accent, but that might come from a xenophobia, right? Which is different than racism. So that was just one example, and other individuals spoke about kind of similar experiences. There's also a healthcare provider preference that I didn't realize was going to end up being a thing. So several participants, especially women, because they were more likely to seek care than the men we talked to, also for chronic conditions and reproductive care. And they indicated a preference for racial concordance more than ethnic concordance. And they also noted differences in how they were being triaged for health and social services. Some of the reasons included being worried about microaggressions from non-Black providers, and also not always being acknowledged as Latino in health and social welfare organizations. So this is one participant who mentioned, when I was previously pregnant and was very intentional about having a Black OBGYN. I float more towards Black physicians because I guess visually, phenotypically, it's easier and I can somewhat trust I'm going to get the care that I think I want to get. But because of societal or things like that, I don't go towards a Latino physician just because I think I'm going to run into the same microaggressions that I typically do, which was not something that I expected to hear, but it was something that came up several times. In terms of invisibility, this participant was interesting because they were an ACA navigator. So they were on the provider side. And they talked about there was like this split. So this participant mentions thinking about people I've talked to, experiences that I've had trying to access especially healthcare, because I think those identities, Black and Latino, are viewed so separately. I know so many, especially darker skinned Afro-Latinx people, who just don't even get offered language services because people are like, you're Black, so you speak English, and or from the US, which is not the case. So there's this concept of like invisibility and like additional layers of need. So for this part of the study, we're really thinking through, participant mentioned that there's just no blending in the context of the US and the South. And Blackness is not always protective and invites some hyper surveillance in public spaces. And behaviors and preferences and resources may not always look the same for Black Latinos in the South compared to non-Black Latinos, and even Black Latinos in more traditional geographies. It looks, people compared to Miami looks different than here, and what the experiences I have, et cetera. So for this contribution, which I have more to talk about here, but I wanted to really think about how to reset the conversation around inclusion of experiences that comprise Latino health and data related to Latino health, and also focus on understudied and underrepresented experiences of Black Latinos. So I know we're close to time. So future work, I'm working through a grant right now to think about creating an intervention to improve emotional mental health of adults with type 2 diabetes in the Dominican Republic, and also integrating that into urban settings of the Dominican Republic with individuals who have multiple chronic conditions. Also thinking related to the second study, as I mentioned, I'm working on a grant right now on how do we validate the diabetes distress scale or pre-diabetes related stress scale to a wider population outside of Latinos. So that's going to be one of the next phases. And then for the last study, thinking about measuring the role of racialization on cardiovascular risk. So I have access to a data set and I'm going to use a racialization measure as a moderator to think through cardiovascular risk of Latinos of different racialized experiences. In terms of contributions, I focus on chronic disease prevention and management with a focus on thinking through psychosocial structural stressors. And I use measurement as one of my areas of interest and do that within US and Latin America and hopefully in maybe other parts of the world. I wanted to thank all participants for all their patience with all these studies, my study team, my collaborators and mentors, and of course the funders who helped with making all this happen. So thank you.
So we're running joke. I'm supposed to go second, but the first person. Thank you, great presentation. Actually just thinking about your second study. I also work on stress, but mostly, so my first question is really about the financial stress component that you asked. Was that financial stress related to the pre-diabetes case or financial stress in general? Just because when we ask about stress in our studies and mental health outcomes, we usually ask about social and financial stressors outside of the specific condition that you have. So just maybe also thinking about potential for collaboration, but yeah.
No, yeah, ideally we want to also have a financial strain or financial stress
Yeah.
kind of inventory as well, because there's things going on broader. But we ask them to think about it in relation to their condition. So money relating to being able to buy the foods that they need to buy. Something that came up both in the US and Dominican Republic, women would often talk about having to create multiple meals because not everyone in the household was willing to change the diet. Men, if they had diabetes or pre-diabetes, everyone had a different diet in the household. But for women in the DR, this happened in the same way. They're like, we don't have money, but I now need to no one's willing to change for me. So I need to make meals for my kids and my partner, but I have to have a different meal because I can't eat that. And so there were considerations about that being a financial strain because it's related to their condition.
Got it, thank you. And then the second question is, have you considered, not to add another study to your work, but would the 15% that you actually managed to identify through clinicians, would that group be so different from the 85% that don't know they have pre-diabetes? That might require another way of thinking about the measurement.
Yeah.
Because I've seen that you were thinking about validating this to a broader population. I'm thinking, is there a way to validate it to a broader population within those who have pre-diabetes?
That's a very good question. So of the 400, so we just got 400, but they all had to know that they had pre-diabetes. So that's a very different group, as you mentioned. It was just in the recruitment phase of this, it was very hard to even talk about it because they knew what it was, but they kept being like, but I know someone with diabetes who could help you with this study. We asked questions about, gestational diabetes, if you had a history of that before, if you have family history, are you worried? That actually still might be helpful because people were worried about family history. They're like, I saw what happened to my grandparents or my parents. I feel like that could happen to me or it's inevitable. So even if they didn't have prediabetes, they're worrying about the inevitability of getting diabetes at the end of the day. So that could be a whole other group. I didn't think about that.
Yes.
But thank you.
Hi, great presentation, Deshira. I was wondering if you could go back to the slide with the polygons around the themes and the multidimensional scaling.
All the themes.
All the themes. I was really interested in kind of this band on the bottom because it's all sort of psychosocial stressors, but the individual stress was the one that seemed to push your worries a little bit. But could you talk a little bit about how you think about all of those pieces which overlap?
So we were able to get solutions at just 3 polygons up to 15. So you can make them as small as you need them to be as overlapping. But when I made them a little bit smaller, like this might move closer to this and kind of overlap. And talking to participants, they felt like somewhat like mental health and anxiety, those are related. So we knew that in theory, within the actual scale, we could probably just put that all under one domain, right? Or subdomain. But I think in speaking with participants, it was easier to separate them out up to a point. We didn't want to do so many that they're like, I don't know what this means. So yes, for individual stress, those were all things that they feel like they had control over, but weren't able to accomplish. Versus the mental health and anxiety, financial stress, that also felt a little structural, what I have access to. This, yeah, you're right. These two could probably be together, but when I try to do a 9, 8, they didn't always clump in the same way, which is interesting because it's all related to how individuals group them. So I have no control on how I would like to label all of these. But I think it still helped me think through, as you mentioned, this band here were all the priorities. What I thought was going to end up being high was patient-provider interaction. And we talked about that in the interpretation sessions. And people were like, yeah, but once you find someone who at least kind of listens to you, even if it's not great, it's better than what you had before. And they're like, yeah, talk to them once every 6 months, it's fine. So I thought that was going to be a bigger deal, and it didn't end up being. So I was actually shocked. I don't know. Holly first.
Okay, so Sarah and I are working on a concept mapping to scale development project right now.
It is so much
for-
work.
It's super fun. So my friend was about, no, it is, I'm a little sick still, but we love it. So thinking about your cluster, like cluster 4 in the middle, because that is like a lot of times items that like people are like, what do you do with those?
Yes.
And then 6 and 7, are those clusters where you ended up having a lot of items that you kept, or did you focus more on the, right, like where? Did
Oh,
your
for the actual
29
scale at the end of
items-
it? Yeah, so I actually indicated what domains I kept near
Okay.
the end, because I was like, I'm gonna need to remember this. So in terms of domains,
Perfect.
I kept like structural, there's this future piece, interpersonal stressors, emotional health, physical health, health behaviors, and communication.
Okay.
So there's a comment, so even patient-provider communication was spelled out
Yeah.
a little bit. Communication also included things like where I get information about prediabetes. That can sometimes be overwhelming. So social media came up a lot, and they're just like, oh, this is where I learned about it, but it also overwhelms me because I don't know what to do with that information. So this is what we have so far. Again, once with the quant data and doing the exploratory factor analyses and things like that, we'll be able to see maybe what ends up falling out a little bit more. I don't think I want to keep a 29 item scale. It just feels like a lot. So.
And I should have started with thank you, that was.
Understandable. Yes, Holly, hello.
That was really helpful, and I loved all of the different areas you're working on. That you happen to do the buzzword of something that I'm interested in, which is shared decision making.
Yes, I know we talked.
I know, and I also, following up on what Steph asked, was thinking that part of why this patient-provider interaction may not be coming out as prevalent is because a lot of these decisions that people are making about either prediabetes and diabetes are really outside of that interaction with their clinician. The clinician might start the conversation, but it's a daily routine that really needs to change. So I was wondering what your thoughts were about your potential thoughts on shared decision making. What decisions are they making and with whom?
Right. So my initial thought within at least a clinic setting of what we could potentially have some impact on, and talking to some of the clinicians and nutritionists and dietitians were really important in this process too, because they're the ones who spend a lot of time. We wanted to understand is if we could create a tailored version of the communication that they were having. For some participants, food is not the issue. Like they're fine with it. That's not their stressor, but it could be pieces of like, I'm really stressed that this is inevitable. So maybe we could have sit for like 30 seconds. A lot of participants felt that prediabetes was not given any time during any clinician visit because there are other things that the clinician had to deal with. They're like, just make sure you eat properly and exercise, and maybe talk to like our social worker if you have time. But they're like, I actually felt like it was a death sentence and I'm going to have diabetes. I talked to people with lupus who felt that they wanted to have more conversation about their prediabetes because they felt so badly about it. And so it was hard to figure out how can we pause a little bit in that conversation to talk about some of the things that may be arising from here. So that's what I was thinking about on the clinician side a little bit. On the community side, I'm thinking through a little bit more, what does that mean for like a community-based intervention? I also wanted to create a pathway or like a little booklet or maybe like a page for adults who have prediabetes and were currently diagnosed to have ways to pause the conversation themselves, kind of activation style a little bit. So like, these are some questions to ask your provider because they don't always know. So like, these are some like 5 questions you can ask at your first session, and then like kind of walk them through a little bit. So I wanted to work with our Latino community groups to think about how to create these like little information pockets for them.
Well, that was great. Really appreciate it. And you have to go to lunch with the dean.
Yes.
I have to get you there.
Okay.
So, or actually, Leah. So thank you very much. That was great. Thank you.